All right. So yeah, this was kind of like one of those things of, hey, I'm shifting my practice from East Maitland to Newcastle. What can I do to just kind of, just get a bit of momentum rolling? And we decided at sort of bit of short notice to put this talk on. So this is one that I really enjoy doing. So I know there's, like yourself, Carly, in the room, professionals. I'm happy to do this talk or a variation of this talk appropriate for the audience at any other stage for different organisations and things like that. So I guess I'll talk a little bit about how I got to be here. So this is me. This is my first daughter, Amber, my second, Oka, and Autumn. So I was literally that kid that couldn't breathe. So I had the chronic rhinitis, I had the crooked teeth, I had the sleep apnea, the snoring, the ADHD. I was literally that kid. I was that package. And my mother took me to all sorts of different professionals. I have vivid memories of going to an ENT when I was a child and having a scope stuck up my nose. I'd gone to various dentists. I'd had CTs of my skull, all of those things. And this is in the 90s and early 2000s. And what we found was that essentially I couldn't breathe through my nose. That was like the crux of it, and that was causing a lot of problems. Thankfully, my mum was a little bit of a hippie, and at the time, so back in the sort of late 80s, early 90s, mid 90s, the story was if there was crowded teeth, they kind of pulled a whole lot of them out, and they pulled them all back in with braces, and they told the child to sort of go on their way. So my generation of millennials, unfortunately, has a whole lot of problems associated with this. Thankfully, my mum was a bit of a hippie. She thought, no, actually, I don't really want to do this. So she took me to a few other places, so naturopaths, and she took me to a chiropractor, which was a terrifying experience as a child. However, I did change my train of thought a little bit as I got older. So as a teenager, I got a surfing injury, a concussion. I came off my surfboard and was unconscious under the water, got pulled out. Thankfully, I was a lifeguard. I was surfing with other lifeguards. They pulled me out, and I ended up with prolonged concussion syndrome. And my mum was going to a chiropractor, and she took me in for my consult, much to my angsty teenage disgust. And I went in, and I didn't like this chiropractor right from the get-go until he started to speak my language, until he started to talk about sport and talk about performance and talk about the fact that, hey, we can work with the fact that you can't breathe through your nose. So he did a lot of cranial work with me, and we worked with a functional dentist. Thankfully, we have one of these in the room tonight, so I'm going to talk a little bit about that as well. So we did a lot of work to be able to improve my ability to breathe, and that was fantastic. That actually inspired me to become a chiropractor. Went to chiropractic college, realised that that was nothing to do with chiropractic college, jumped through the hoops of chiropractic college, graduated, and shortly after had my first daughter, Amber. So Amber was a lovely home birth. We have a doula in the room. But during the birth process, she sort of had her head up into the side, and she developed a torticollis. She was also born with a tongue tie that wasn't identified at the time, but we had massive amounts of latch issues, like horrific. I thought I knew because I'd already done a little bit of paediatric study as a chiropractor, and I was really interested in children and well-being. And I thought I knew a wee bit until I had a child that had some challenges. So she had a torticollis, which developed, so that's where the child's neck is sort of stuck in one place, which led to a plagiocephaly, which is where you get the misshapen skull. So that's where the plates of the skull mould according to sort of lines of forces, and of course a tongue tie. And I didn't really know anything about any of these things at that time, and I decided I wanted to learn more. So in order to be able to help my own daughter and other children in my community, it sort of drove me to do a whole lot of postgraduate studies. So I did neurodevelopmental pediatrics and craniopathy, and subsequently had my other children, both of whom who had behavioural and airway issues. So I've learned a lot from my children, and that's really inspired me to actually go out and serve my communities, because I thought if I don't have the resources to help my own children, who's going to have them out in the community? So that's my backstory. That's how did I get here, and how did I get so passionate about the work that I do as a chiropractor. So the mouth. Okay, I'm just going to also pre-frame in this room. I know we've got like quite a diverse audience here. We've got people who've got more experience and knowledge than me in chiropractic. We've got people who are working professionally in the fields that probably already know a lot of this. But just understand that I'm going to sort of target it to the people in the room that maybe this is new information to. Yeah. So the mouth is a small space, but it has a really big influence. So when we think about the mouth, we usually think about eating, we think about talking. Those are kind of our primary functions that we think about. But if we think about a child's mouth, it's doing much more than that. It's hugely connected to the brain. It shapes how the face grows, the whole face grows. It influences our breathing and our sleep. It's very much an important part of our digestion. It even plays a role in our posture and our emotional regulation. So it's a surprisingly powerful little space, all this sort of oral structure. And the reason for that is that it takes up a huge amount of brain real estate. So this little funky guy over here is called the homunculus of man, and it's a visual representative of the sort of sensory motor parts of the brain and the amount of real estate that it takes up. So we can see here that the mouth takes up a massive amount of real estate here. It's huge. It's even more than the genitals, interestingly enough. So, and we think that those are very sensitive areas. So if we think about the amount of brain real estate that it takes up, and we think about, as a chiropractor, what I do, which is working with the nervous system, it's really important that we understand and know about the oral structures and how it relates to the brain function and brain development. So in the big picture, the mouth is a sensory organ. It's got a huge amount of sensory nerve fibres in and around the mouth. It's a motor organ. It's got more complex movement within the mouth than anywhere else in our body. It's a respiratory regulator in that we need to be able to have the strength of lip closure in order to be able to maintain good respiratory regulation. It's a digestive initiator. Chewing is a really important part of digestion. It's an immune interface, meaning that we actually need the mouth to be closed and breathing through the nose to be able to have our immune system functioning well. I'm going to talk about that in a little bit more later on. It's a structural architect. So the structures in and around the mouth drive the architecture of the entire skull and, interestingly enough, the entire musculoskeletal posture. It's a communication portal, not only in vocal speaking, but also in our, when we relate to young infants, and it's very much an important part of our social interactions. And it's a neurological driver. It's a huge gateway to the brain. So it connects directly to the brainstem, to the cortex, our airway, gut, spine, immune system, and all of our social circuitry. It's a really important part of that. So it's where development begins and regulation is shaped, and it's where structure and function meet. It's a really important structure. So what does ideal oral posture and function look like? So this is where I just want you to kind of start to think about maybe, children that you know or people that you know, and start to connect some of these dots here. So in an ideal balanced face, what we've got is we've got nice sort of broad skeletal structures. So the skull this is the normal sort of shape of the skull, model skull. You can see the palate there, it's kind of the shape of the tongue. Okay, that's an important thing to remember right now. We've got our eyes are nice, balanced, even, they're straight, they're bright eyes, we've got strong cheekbones. Don't look at my face, by the way, I'm not a good example of this. We've got a defined jaw, we've got wide ears or wide nostrils. This is like a nice balanced face. What we see more and more is we see these elongated faces. Mine's a bit more of an example of this. Elongated faces, uneven teeth, open mouth posture, dark circles under the eyes. And this is where we start to see some asymmetries as well. And there's a lot that's actually behind this. So in an ideal function, we want to have the lips closed, we want to have nasal breathing, and the tongue is positioned on the roof of the mouth. Our eating, drinking, and chewing and swallowing breathing should all be managed with the mouth closed. So we should be able to, once we get the food in the mouth, we should be able to keep it in there. There shouldn't be excessive drooling. We shouldn't be, having to force food forward or open the mouth to swallow. Speech is clear and age appropriate. So this is going to vary from child to child and also birth order. There's a lot of things that contribute to speech, but there's like these windows of age appropriateness of speech. Saliva is swallowed and well controlled. So how often do we see kids that have trouble managing saliva? Actually, adults that have trouble managing saliva too sometimes. And teeth are aligned and the jaws are balanced. We get what the dentists call good occlusion. How often do we see this? Not very often, really. No. So this has been a problem that's been developing over a long period of time. There's lots of contributing factors to this. So in prehistoric skulls, what they found is that there's these nice broad, this is the maxilla, by the way, the top part of the jaw here is called the maxilla. So this upper part of the jaw is really nice and broad. It's got space for all of the teeth. And that means that this part here, which is our airway, is nice and open, okay? What we're finding, and even like as early as the 1940s, and it's been getting progressively worse, is that we're getting this narrowing. Now, there's a lot of contributing factors to this. Everyone read the book by James Nestor, Breathe? Anyone come across that book? Yeah, okay, really good book, highly recommend it. It talks a lot about the breathing, talks a lot about jaw development. Now, I'm going to break it down even further. So at around about 7 weeks in utero, we form what's known as the cranial base. So that's this part of the skull, this middle third of the skull. So that's about week 7 in utero. And a lot of women don't even realize that they're pregnant at that time, or, you know, it's very early on. So at about week 7 in utero, we form that cranial base. That's very reliant on the bioavailability of some particular fat-soluble vitamins, A, D, E, and K2. These were very prolific in our prehistoric diet. We had them a lot. They were a lot in animal sources and organ meats, and they were far more available. In our modern diets, we just don't have that bioavailability of those fat-soluble vitamins. So that is a significant contributing factor. We've also had the degradation of our food sources over about the last 7 generations. So just even if you're, you know, one of those amazing people that buys organic food or grows your own food, things like that, we're still going to have deficiencies. What that means is that we, right from the get-go, don't necessarily have that cranial base forming well. We then have, in utero, that tongue movement starts to happen very, very early on, and the tongue is a really important driver of this growth. And we're seeing far more incidences of tongue tie at the moment, which is part of lots of different influencing factors, but in particular genetic SNPs. So, and these are often environmentally triggered. So there's a lot of things happening in our environment that are causing more and more tongue restriction in utero, which then drives this pattern as well. We then have a lot more birth intervention. We have lower breastfeeding outcomes. There's so many different contributing factors to this, but essentially our ancestors had it sorted, and we're missing the mark. These are really important things that we're missing. So what it means is that right from the get-go, sometimes these children are just born with a limitation of that growth through the middle third of the skull. You know, unfortunately, we've got about 7 generations of it. And this is what, you know, I found, particularly with my 3rd child, which I'd started to know a lot of this stuff now. So I was doing a lot of the things to implement the change and, you know, dietary and early interventions and things like that. And she still required quite a lot of work, and she's still in an expansion plate. We've kind of got a bit of a limitation in our modern diet. So these are things that we need to take into consideration, that our ideal that we saw before is a bit of a unicorn. We don't see it very often now. So this is something that I feel like is an important conversation to have with anybody that's working with children or has interactions with children, of knowing how to look for this and what we can do about it. So mouth breathing versus nasal breathing. So this is actually a video. Let's see if I can make this work. Okay, so when we're nasal breathing, we have the air coming into the nasal cavity. So you can see these turbinates in here. These actually will warm and filter the air. We've got a specific chemical that's released within the nasopharynx that also acts as a filter, helps to open up the blood vessels, helps to open up our airway, helps to kill these viruses, helps to regulate our blood pressure. And that funky little chemical, nitric oxide, is released through these paranasal sinuses. So we get snot formation. That's good. We want that. It helps to clear out the pathogens in the environment. So what happens conversely is if we breathe through the mouth, we don't get that warming and filtration of the air. And this tonsillar and adenoid tissue at the back is not designed for that onslaught. Okay, so from an evolutionary perspective, we've been breathing through the nose. We haven't been breathing through the mouth. So this tissue therefore kind of goes, oh my God, I'm not ready for this. And it has a subsequent immune response. It does the best that it can, but it's not designed for that onslaught. So we get the swelling, we get the kids that have those swollen adenoids, which then reduces this airway even more, and the swollen tonsillar tissue. So what's happening here is this person is having a really hard time. So the body in its innate wisdom drops the tongue down. We should have the tongue resting up on the palate. Drops the tongue down in order to be able to open the airway. So when we've got the tongue pressing up on the palate, it actually starts to stimulate some of that action that's happening within the nasopharynx to open it. But when the tongue drops down and we're breathing through the mouth, we start to get a lot of problems sort of at the back of the throat, immunological responses, but also we don't have the pressure of the tongue on the top of the palate here, which is going to be holding the space there. Okay, so it's kind of like the supporting structure. So this is where we get what's known as the narrowing of the arch, and this is where we get the crowding of the teeth and subsequent problems with that. So when we get that narrowing, it's not just sort of on this dimension. What happens is this whole bone here cathedrals up into this nasopharynx and blocks that airway even more. So this is part of the issue and the difference between nasal breathing and mouth breathing over a long period of time. The other thing is when the tongue's low, it can't elevate properly to swallow. We start to push it forward, and that causes all sorts of other problems around the teeth as well. So coming back to our shape of our face, when we've got the tongue in the correct posture, we've got the closed mouth, we're getting nice nasal breathing, we have this kind of, it's actually called a McCourt's mask. Has anyone come across the golden ratio? So golden ratio, Pythagoras, pi, you know, how things grow, the conch shell, Leonardo da Vinci looked at it. Yeah, okay, all right. So everything should grow in this sort of like symmetrical progression. Divine, yeah. What is it called? Divine ratio. Proportion. Divine proportion, yeah. And so the human face has actually been mapped, interestingly, by a plastic surgeon, and it was called McCourt, and it's called the McCourt's mask, and he can overlay essentially the dimensions over any face, and if it's within this golden ratio, the proportions will fit within that. Okay, and that's actually a measure of beauty, interestingly enough, because our eye is drawn towards that golden ratio. This is why when we look at a rose, we go, oh my God, it's so beautiful, right? Because our eye is naturally drawn towards that. So a face that's got these correct sort of forces and growth forces is actually more beautiful. And then a face that's actually kind of doesn't have these forces and it's changing the shape of the growth trajectory, it actually doesn't fit within that McCourt's mask, and we don't see it as visually beautiful. How this affects the posture. So we have huge connections between the mouth musculature, the tongue musculature, and all of the neck musculature. Okay, there's a lot of neurology behind that. But one of the simplest ways that I describe how this affects our posture is that if who's done CPR before? Yeah, right, okay. What's the first thing that you do when you're opening the airway? Your head tilt. Okay, all right. So what we need to do in order to be able to open the airways, we need to tilt our head. Well, we're not going to do that when we're biped and upright, but the brain in its innate wisdom is going to go, my airway through here is compromised. So what I'm going to do in my innate wisdom is I'm going to bring my head forward to open my airway. Okay. So as a chiropractor, I x-ray most adults that come in because that's, you know, from a biomechanical perspective, a safety perspective, it's really important that I do that. The majority of adults, and actually now adolescents that I'm seeing, will have forward head posture. A lot of times we think it's technique, yeah? We think it's because they've got their head down looking at their devices all the time. But in actual fact, the brain will drive the head forward far more neurologically to maintain an open airway than it will to look at a device. So the airway has a huge influence on the postural changes that we're seeing. The other thing is that the brain will always level the eyes with the horizon. So we're not going to do this. We're going to bring our head forward, and then we're going to bring our eyes level with the horizon to make sure that we're upright. So that's why we get a huge strain. These muscles at the back of the neck that connect the back of the head to the top of the spine, tiny wee little muscles, have huge nerve innervation. They give our brain a lot of information about where we are in space. So when there's that huge amount of pressure with the forward head posture on those muscles, it makes all of the rest of the posture compromised and all of the rest of our neurological function compromised. Our brain is actually running on overdrive because of our airway. The other thing is that when we have our head forward, we're not recruiting our main primary breathing muscle as effectively as we can. So the diaphragm, so it's a big flat muscle through the middle of the abdomen. It is what is kind of part of our breathing mechanics. So when we breathe in, the diaphragm moves down and out. It's not playing, it should actually have got a little animation of that, so we should be able to see it. So the diaphragm moves down and out when we breathe. That expands the ribs. And so that's when we breathe in. When we breathe out, it relaxes. When that's not working effectively because of this altered breathing mechanism, we start to recruit these muscles, our accessory breathing muscles, SCM scalenes, and that brings our head forward even further. When our diaphragm tightens, it affects how we engage our core. So the diaphragm and the pelvic floor work in synchronicity. If we don't have the diaphragm moving effectively, it starts to affect our pelvic floor. So this then affects all of the other aspects of our core and posture as well. So the analogy I like to use is like one of those kombucha cans. If we put one of those kombucha cans out closed and we stood on it, we'd be able to stand on it. As soon as we open it and stand on it, it loses its structural integrity and it's going to buckle. So the diaphragm acts the same. If we are not breathing effectively, which I'm not at the moment because I'm over talking and over breathing, I'll get to that. But if we're not breathing effectively, what happens is that when we then load our core, we're going to buckle. And the area that buckles tends to be our spine, because our organs are designed to squish around and our abdominal muscles are designed to move around. But what's going to take the brunt of that is our spine. And we see that as chiropractors in our x-rays as well. And also the fascia. Fascia is such an interesting thing. It's connected right within these little fascial components between the brain hemispheres within the skull, the outside of the skull within the cranium, all the way through the system that link all the way through our body. So the fascia is a really interesting component in this. So the immune and gut connection. So saliva has lots of protective factors, which is really compromised when we don't have closed mouth posture. So when we are breathing through the nose, like I talked about before, we're dealing with a lot of those pathogens. When we breathe through the mouth, it's not designed to do that over a long period of time. The mouth needs to be closed. We need to be able to manage the saliva in our mouth for the pH to remain, relatively neutral within the mouth. When we have that alteration of the pH within the mouth, when we're breathing through the mouth, we're introducing pathogens and also changing the pH, which makes it like a hospitable environment for the bacteria that can start to cause a breakdown, not only of the oral structures, but once we start to introduce that bacteria into the mouth, it affects everything else as well. The other thing is that when we're not actually having the mouth working as well in terms of chewing and breaking down the food, it starts to affect how the gut works down the track as well. So CO2 and nitric oxide. So we often just think about oxygen in terms of breathing, but CO2 is our major driver. So CO2 will actually trigger whether or not we need to breathe again, as the amount of CO2 that we have within the system. I'm not going to go into too much chemical detail about it tonight, but I just want to think about, I want you to just think about what is our capacity to manage CO2. Because most of us in the room here, unless we've done specific breathing work, we're probably over breathers. I'm doing it at the moment again because I'm talking, which means that my ability for my brain and my body to hold CO2 is less at the moment. That's not good. That means that I'm not absorbing the oxygen. It means I'm not absorbing the heme. It means I'm not transferring other nutrients. So it's a really important thing that our bodies can actually manage CO2 well. Nitric oxide, that's that cool little chemical that I was talking about that's only produced in the paranasal sinuses. We don't produce it anywhere else. It's really important for dealing with pathogens. It's really important for dilating our blood vessels, our other respiratory tissue. It's really important for managing our blood pressure. It's a really, really important component. We only produce it in the nasopharynx. If we're not nasal breathing, we don't produce it. It really compromises our health. So the other thing about the mouth is it's really important for our speech, our emotional expression, regulation, and confidence. So the mouth and speech, they also organise the brain. So we've actually done some studies. So these were studies that we did last year before, which is where we put an EEG, which is measuring the electrical activity in the brain, on a whole lot of chiropractic students' heads, and we measured what was happening in their brain when they were chewing. So we measured what was happening in their brain at rest, we measured what was happening when they were doing what we call a sham chew, and we measured what was happening when we introduced what's known as a myomunchie, which I'll talk a little bit about tonight. And what we found is that the brain actually starts to fire up the areas that are associated with all of our essentially human aspects of our brain. So a lot of the prefrontal cortex, so our memory areas, our attention areas, our emotional regulation areas. Interestingly enough, another study that was done with chewing was done on adolescents that had a tendency towards self-harm, and the group that was studied were given the chewing appliances, the Maya Munchies, and their incidences of self-harm actually reduced massively. If we think about what's happening in an adolescent in self-harm, is that they're actually trying to calm the nervous system in doing it. I know it seems counterintuitive, but that is what's happening. And so when we were giving them another input to help to calm the nervous system, it was actually stimulating those pathways, those neuroregulatory pathways and emotional regulatory pathways, just through a different mechanism. So the thing about the mouth in terms of social interactions is that, you know, when babies coo and like babble and they start to mimic and they copy you, that's really, really, really important. So when we're born with very much primitive reflexes. We're not born with all of the kind of like cool adult functions of our brain yet. They all grow and develop over time. Yeah, sometimes it takes like 28 years. No, but you know, it takes a while to develop. But when a baby is mimicking and when they're copying, when they're babbling, they're actually activating those pathways, those really early pathways, the right hemisphere, which is all about our ability to form relationships with other human beings. And that's going to set them up for the rest of their life. So, and that's so much based around the mouth. If you've ever worked with babies really closely and you're watching them, they watch your mouth. They're watching your mouth. You know how babies, you know how we've got those little contrast books for babies? Yeah, the black and white. Yeah, okay, that, from an evolutionary perspective, we haven't had black and white contrast books of cows and cats, right? We've been able to see contrast. The most highly contrasted part of a human being is the face. So babies have evolved, their vision has evolved to be able to see contrast, which is to be able to see their primary caregiver's face and start to recognize that. And the first thing that they recognize is the thing that moves the most, which is the mouth. So it's a really important social developmental aspect as well, is how well the mouth moves. If we've got an infant that can't move their mouth appropriately, and I see this quite often in practice when I've got infants that have got some cranial nerve disruption, and you see those little babies that almost like they have that perpetual frown, right? And that's because those cranial nerves aren't actually activating properly. They're not able to change their facial expressions well. And what's happening is that because the baby's frowning, because we as humans mimic the people around us, the adults frown back to them. So then the babies learn to frown more, and then the adults frown more back at them. And so you've got these poor little babies with this terrible affect of they actually start to not develop that ability to smile. And I have to say to the parents, hey, look, this frown thing, that's just because they haven't woken up those muscles to express themselves yet. I was like, you need to show them how to do this by being really expressive. Please don't frown at them. They're not actually angry at you. Like, please don't interpret it as that. They don't have the higher cognitive function yet to be angry at you. So it's really important that we actually start to, you know, mimic and show those massive, big facial expression changes. The other thing actually on that, has anyone come across the still face experiment? No? Oh, okay, really scary. Right, so this is where they had infants in a room and they studied their social affect, so how they responded to their caregivers when their caregivers went blank. All right? It's terrifying. I advise you go and watch it on YouTube, because this was done, I think, in like the 70s, prior to us having devices. Yeah? So what was happening is that the caregiver was interacting with the child, they're chatting, they're playing, and then the parent went blank, the caregiver went blank. And the child becomes progressively more and more and more distressed, because we rely on vocalizations and facial interactions in order to be able to regulate our social affect, to know that we're safe, right? We can tell when our partner's a bit miffed at us by their facial expressions, right? Yeah. So we rely really heavily on that, and we learn that very early on. So what was happening is the caregiver went entirely like blank for a period of time, and the baby became more and more and more distressed. They actually had to stop the experiment because the babies were becoming too distressed. And so then when the parent then started to engage with the child again, the child was really quite confused and was like, oh, what's going on here? And it causes a little bit of like what can lead to disorganized attachment. What do we do when we look at our devices? So blank, right? What's happening with the parents at the moment? And I'm guilty of this too with my third child. Yeah, a little bit. I was like reading stuff while I'm breastfeeding her. Like, I'm guilty of this as well. It's a current modern world that we're in. But this does have an influence on how these children are learning to socially interact and move their face. Anyway, I digress. Okay. What was that, sorry? Botox, yes, actually. I've seen that more in Australia than I did in New Zealand. I don't think we really care about appearances as much in New Zealand. We're a little bit. Anyway, so latch-in feeding challenges. All right, so many people I know in this room either work in this field or have experienced latch-in feeding challenges. I'm one of those people. Again, this was one of my drivers to actually do this. If anyone's fed an infant who has dysfunctional tongue movement, it's like your nipples going through a cheese grater. It's not nice. So this is sort of what we're looking at in terms of an ideal latch, all right? So there's a lot of breast tissue in that infant's mouth. That mouth should be able to manage that, right? That's what we're designed for. When an infant is born, their brain function is very much based on survival. It's all brainstem oriented, it's downstairs brain, it's primitive reflexes, and most of them are associated with breathe, suck, and swallow. Survival, okay? When we have any sort of interruption to that, that is a variation away from normal. So breastfeeding is our biological measure of normal. Has anyone come across the delivery self-attachment video? So this is a really interesting one, which is where when we have an infant that's born with no interventions, it crawls up to the breast, okay? So we have all these amazing innate reflexes that will drive that, provided that we don't have any interference to that. So there's a lot of things that can cause interference to that. One of the biggest things that we see currently, and again, there's a lot of environmental contributing factors to this, is tongue ties. And so there's various different grades of ankylosing. There's also other ties that can happen as well. So there's lip ties, there's buccal ties, there's lots of different ties that can happen. I don't want to go into too much detail because sometimes I'm looking at my laptop late at night and I'm reading about, genetic mutations, and I just have to close it because I've gone down a rabbit hole. But essentially, what we're looking at is that when we're in utero, in order to be able to get the structural kind of landing, we have all of those tissues tied. That's normal, okay? Once everything's kind of in place in utero, in about sort of 15 to 18 weeks in utero, then what should happen is that this tissue should start to die off. It's apoptosis, it's normal cell death, okay? Sometimes it doesn't, and so that's where this infant now has a tongue tie or ankylosing or other sort of tie. The tongue's a really interesting one though, because the tongue should really have this really nice peristaltic wave as it's swallowing. Babies start swallowing really well at around about 18 weeks in utero, and so they're swallowing the amniotic fluid, which is kickstarting a lot of different systems within their growth and development in utero. If they can't get that elevation in utero, they're already kind of on the back foot. And so then if they have any sort of birth trauma, again, they're on the back foot. So then we see them come into the office, and Carly, you'd see them come into your office looking like this and variations of this. This little mandible, so the lower jaw there, being quite regressed because it hasn't been able to sit appropriately in utero. So this is something that's happened for this poor little bub in utero. It's not something that's happened just in birth trauma. We have open mouth posture because we've got low tone. And when we have open mouth posture, their little tongues are sitting low. They're not sitting up on the roof of the mouth. And then this one's a really terrifying one. I don't like when I see this one, which is the tongue just hanging out of the mouth. That's the brain going, I've got no idea where the tongue is, and I don't know what to do with it. It's even worse when I've seen these ones that have already had tongue tie releases and then they come into my office and I'm going, oh, because what's happened is we've got a tongue that's hypermobile but completely under-facilitated. The brain doesn't know where it is, doesn't know what to do with it, and it's just a bit of meat that's hanging out of the mouth, and they're really terrifying. I mean, how often do we see our friends, cute little babies, or people that we see, cute little babies, looking like this? Yeah? Once you see it, it's really hard to unsee it, yeah? So we need to start to be aware of these things, and we need to start to notice this dysfunction right from the get-go, right from very early on at birth. So interestingly enough, as a result of any sort of oral dysfunction, we often get a misuse of thumb and pacifier sucking. I actually just wrote a blog about this, so I'll share the link to this. As I talked a little bit about this in a bit more detail from a parent perspective. So coming back to this skull, we have a look at the top here. You can see it's the shape of the tongue, right? And that's because the tongue should sit up there. It's designed to sit there. That's its home. We've got a lot of nerve fibres up the front there as well, and we've got a growth centre at the front here as well. So we need the tongue, which is a really strong muscle, to be pressing up there in order to be able to stimulate these growth centres at the front of the top of the jaw, but also to be able to stimulate all of those nerve fibres, which help to calm and regulate the brain. It's really, really important that we have the tongue there. So the child that is having trouble with getting the tongue there for various different reasons, their brain in its innate wisdom will compensate, okay? So they'll put their thumb there or their fingers there, and then they'll create the habit because they're getting the inputs that they need, but it's not ideal. Now, sucking should be something that does land, particularly in the first sort of 10 weeks, and some babies have a little bit of trouble with that, and this is where there could be an appropriate use of a pacifier, and there's lots of really cool designs out there now that actually help babies land that sucking, okay, especially if they've had any sort of challenges. I'm not saying don't use pacifiers, because sometimes there is like a place for them. The thing is that with any sort of non-nutritive sucking, we need to know why it's happening and what is actually driving that need for that pacifier. The other thing is it's just like cigarette packets that come with all the warnings. I feel like we need to have this on pacifier packets, okay? Because parents often come to me when their child is like a year, nearly 2 years. I've had a 4-year-old come in and they are still using a pacifier, right? But there's no warnings on the packets. They get the orthopedic pacifiers or the best quality ones, but the thing is that the child shouldn't be sucking anymore. So in terms of brain development, a child's, we know that babies hold their head up and they push themselves up and they get up onto all fours and they crawl and then they start to cruise around, they walk. We know motor milestones, right? They're really obvious ones. We get taught those. Did you know that a child should go from sucking to chewing at around about 4 to 6 months? Yeah, well, you guys did, but we don't get taught that as parents. We don't get taught that actually, from a neurodevelopmental perspective, it's really important that the child stops having sucking as that primary movement of the mouth and it starts to become chewing. That's a really important milestone that gets missed, and it's not one that's put on pacifier advertising and packets. And pacifier companies keep selling pacifiers without any other sort of information, or education, or advice. So if we don't have the tongue sitting there and we've got the thumb sitting there or we've got a pacifier sitting there, it will start to force that growth in an unusual pattern, and we get what's seen here, which is called an open bite. And oftentimes we have a dysfunctional swallow pattern with this as well, so you can see the tongue sitting low and it'll push forward when this child swallows. The thing is that I see, and you'd see all the time, really distressed families. Like really, really distressed. This child's colicky, this child's not sleeping, they're not feeding, they're not thriving. The pacifier does serve a purpose, but we need to figure out why are they relying on that pacifier and what can we do to start to introduce the normal neurodevelopmental pathways. So I don't say all this to shame pacifier use at all whatsoever, because there is a place for it, but we just need to start to recognise patterns and interrupt them if we can and get back on the right trajectory. How often do we see this in young children? Yeah? Oh, it's really cute, she's asleep. We should not see this. We should not see open mouth. So this is really low muscle tone. So muscles are a use it or lose it situation. And because she's not having this lip closure, because she's not using those muscles, they are getting weaker and weaker and weaker. Because those muscles are getting weaker and weaker and weaker, they're not putting the forces on the bones to make them grow appropriately. And you can see already these two teeth, the two top teeth here are touching. Those two top teeth at her age shouldn't be touching either, okay? So she's already sort of quite narrow through there. So she's getting the onslaught in her tonsils of the, her poor little airways compromised. Her adenoid tissue will be really enlarged. And it's also will change her sleep architecture. So sleep architecture is like the different phases of sleep that we go through. So up until around about 5 years of age, we've got very sort of young child sleep architecture, but from about 5 years of age, we actually should have more adult sort of sleep architecture. We should have cycles of REM and deep sleep and variations along that. When we have this obligate mouth breathing, like this child here, it doesn't allow us deep sleep and it doesn't allow us restorative REM sleep either. So we've got really disrupted sleep architecture. they call it sleep disordered breathing, but it's actually more breathing disordered sleep. So the way that the child is breathing is actually affecting their sleep architecture. This then leads to the nervous system being really on edge. Okay, so when we run away from the cave lion, we breathe through the mouth, right? It drives that stress response. When we don't have the tongue resting on the spot, it starts to drive that stress response. When we have that brain that's actually right from the get-go sort of been in that pattern, it forms that way. So we get a neuroplastic change. Interestingly enough, up to 25% of children diagnosed with ADHD actually have sleep disordered breathing. So they will have sleep apneas. And children with sleep disordered breathing are 50 to 90% more likely to develop ADHD-like symptoms. Actually, by the way, this has changed. I did this thing in 2024, and there's been more studies that have come out that has actually got a higher correlation with this now. So what happens is that we are rewiring the brain into a stress response, which means that we don't have the ability of the prefrontal cortex to be able to reuptake dopamine, which is then what drives the ADHD symptoms. Okay, so chicken egg, like there's a lot of things that contribute towards ADHD. It is a structural and functional difference. There's a lot of genetic components there as well. But then you add in sleep disordered breathing and it's going to drive that pattern even more. So this is where when I get children that present with ADHD, I say, you know, cool, great, me too. Like I've got a brain that's structured a little bit different as well. But if we can actually mitigate some of the other things that make it really hard for your brain to work, such as the open mouth breathing, that's going to help that child massively. So it's not the cure to ADHD, but it's certainly going to help that brain that is a little bit, you know, more challenged function a bit better if we can get on top of their breathing. Snoring. Anyone in the room snore? Yeah, all right. So snoring is, again, that same pattern, just, you know, we're starting to see it, you know, progressively as people get older. So we lose that ability to be able to maintain the airway. So what's happening is that because we have got that low tongue posture, we're not getting the tongue up on the palate, because we're not swallowing appropriately, we lose that muscular tone with the back of the tongue. We don't have the mouth closure, and so we end up having the open mouth breathing. And even people will snore with closed mouth because, again, we've got that loss of... So people can have their mouth closed and still snoring because we don't have this tone here at the back. And so it hugely shortens people's lifespan and health span. Right? So snoring is a massive red flag. Athletes. So there's a difference between these two athletes here. So an athlete with an open mouth posture and like high exertion, open mouth is appropriate, but not for an extended period of time. So she's going to be recruiting far more of this anterior musculature. She's not going to biomechanically have like optimal posture for firing her muscles. And she's not going to be really getting the most out of her performance. Whereas like this athlete here, with her mouth closed, she's nasal breathing, she's going to have a better posture, she's going to have a better recruitment, she's going to have more efficiency. I love watching the Olympics and watching like who's got their mouth open, who's got their mouth closed, and performance. I'm an athlete whenever I've got my mouth open. Unfortunately, I'm not quite that. So, how are we going for time, Connor? Okay, all right, I'm not going to do that, but I'll send you this. So this is just, it's a test to see how well you manage CO2, but I can send that out to you. I'm going to give you a few things that we can talk about that are actually going to improve what's happening in terms of the mouth, and the mouth matters. So chiropractic, there's a lot of the work that I do is really quite nuanced, cranial, really intricate work that I've gone and learned over a number of years. To be honest, what I use day to day is exactly the same as the other chiros in this room. We check and adjust subluxations. We're making sure the brain can talk to the body can talk to the brain. It's really simple. We don't have to do all of this other stuff all the time. I tend to find that the big idea of chiropractic is that our brain has a map of where the body is in space. Okay, we need the body to be moving appropriately to maintain that map. When we've got an area of the body that's not moving appropriately, the brain has a blind spot. It makes it up. This is where we get compensations. This is where we get symptoms. This is where we get breakdown. Because the brain's going, I don't really know where this structure is, so I'm going to just do my best, but this is where we get a breakdown. So what the chiropractor does is they come in and actually address to see where is the area of the body not moving appropriately, and that's what we call the subluxation. We make the adjustment. The brain then has a much better movement input of that area, and it can reform that map more appropriately, and it can respond more appropriately. That's the really basic neuroscience of chiropractic. So because of, again, if we can kind of go back to that funky man at the beginning, the homunculus, showing just how much of the brain real estate is taken up by the mouth, massive. So when we reduce the subluxations, particularly in that upper cervical area, it has a huge influence on how our brain can be aware of and can control and coordinate the mouth. That's pretty much it. So what we do as chiropractors is really unique, and it has a huge influence on the mouth. But there's other things that we can do as well. So this little exercise I'm going to give you is how to clear your nose. Oh, the video's not working. That's okay. I'm going to go through it with you together. Okay, so what we're going to do is we're going to take a breath in and out through the nose. You're then going to close your mouth. You're going to pinch your nose, close. You're going to nod your head up and down, up and down, up and down until you feel like you need to breathe again. You're going to keep your mouth closed the whole time, and then you're going to breathe through your nose again, okay? On the inhale. So we breathe in and out, pinch the nose closed, nod your head up and down, up and down, up and down, and up and down. When you get that hunger for air again, make sure you keep your mouth closed, release the nose and breathe in again. So what you should notice is that actually clears your nose a little bit for those who might have had a little bit of congestion. So that's a really great technique that you can use yourself. You can actually teach your kids. This one's really easy. This is my videos, my daughter actually doing it. It's a really good one to teach kids. If they have trouble, they go, oh, I can't breathe through my nose because my nose is blocked. It's like, cool, well, I've got a magic trick that's going to unblock your nose. You ready to do it? Yep, so that most of the time it will clear the nose for them. All right, so that's one of our little takeaways. All right, saline rinses are really, really cool to do. Okay, we're exposed to so many different things that will irritate our really sensitive paranasal tissue. So if we can kind of clear that system out on a daily basis, it makes a huge difference. So a saline rinse is a really nice thing to do. You use hypertonic saline, which is like that extra salty saline, which will actually help to draw moisture out of the sinuses as well. So this is just an easy thing to do. You do it right from infants all the way up. I find that young children who are a little bit opposed to this, if you make it fun and you use like a hypertonic aerosol spray, that can actually work quite well. It doesn't have to be the whole squeezing thing up through the nose. But if you can get kids used to doing a saline rinse, it makes a huge difference to when they do have congestion, and to help to keep that system clear, because we're just exposed to so much these days. Essential oils actually do play a really huge part. Like, we can utilize them as a means of actually opening up the sinuses. I like to get these little kits here and just put that. By the way, I don't do doTERRA. That was just the one that came up. Whatever you want to use, eucalyptus, peppermint. There's all sorts of different oils that you can use. But you can get these little kits here that you just put the essential oil on that, put it inside there, and it's kind of like a little snuff thing that you can carry around. You just get them on like Amazon. Tongue to the spot. So what I want you to do is put the tongue just behind your teeth. Yeah? Okay, so that is where your tongue should be resting. So there's little exercises that you can do during the day. So tongue clicks. So that's where you can kind of wake that up. I teach babies to do that. So when I'm working with babies, I'll get them clicking right from a very early age. You can do tongue suction holds. Again, sorry, the video is not working, but this is where just before you make the noise when you click, your tongue should suction up to the roof of your mouth. This is a really good thing to do in a mirror. Yeah, I don't drive here, I haven't got my driver's license here, but when I was driving in New Zealand, I'd use my rear vision mirror and I'd be like, just doing my tongue suction holes while I'm driving along. So this is a really good thing to do. So practice it with your mouth open so you can see what you're doing looking in a mirror, but then try to practice it with your mouth closed. That starts to retrain the tongue to sit on the roof of the mouth, because a lot of us in the room may not actually have the tongue sitting up on the roof of the mouth. Slow down your breathing. Again, the video is not working here, but this is a method called box breathing. Is anyone familiar with the box breathing? Yeah, so it's in for a certain count, often it's 4, you're holding for a certain count, you're breathing out for a certain count, and you're holding for a certain count. What that's doing is that's increasing your carbon dioxide capacity. Okay, so that's a really simple thing that you can do, and that's a simple thing that you can do with kids. Train your diaphragm. So another really simple thing that you can do is you can put a little strap belt or something around the lower part of your ribs and cross it over. When you breathe in, what you'll notice is your ribs will push out against that. When you breathe out, you can put a little bit of tension on it, and it starts to retrain the ribs. Breathing in, breathing out. Ribs come in, breathing in. Ribs go out, breathing out, ribs come in. Okay, so retraining the diaphragm. You're going to massaging the diaphragm. I often get parents to actually do what we call the rib hugs with kids, with little kids. So we're actually just doing a nice broad sort of hold around the ribs, and we're massaging in and around and underneath the ribs. And this helps to retrain the diaphragm. Also gets that proprioception of the brain knowing where the diaphragm is. And chewing. Chewing's really important. This video is really good. Sorry, this one's working. Yeah. All right, so our ancestors chewed a lot. We were chewing for like 4 hours plus a day just to get our nutrients that we needed from food. So we're designed to chew. Chewing is very, very important. We've chewed over a millennia. And what happened is when we had the introduction of the agricultural and particularly the industrial age is we outsourced our chewing. We outsourced our chewing to canning and freezing and processed foods. So we need to reclaim chewing, because just like we go and exercise at the gym, we need to exercise our jaw. So because we're not out hunting and gathering, we go to the gym, we go to Pilates, we do all these other things in order to be able to maintain our physical fitness. We need to be able to maintain this physical fitness as well. And this is where chewing is really important.
Does chewing gum count?
Chewing gum is good, but caveat, people often end up chewing unilaterally. So they'll have a preferential side and they'll chew only on that side. The other thing about it is that if they've got a dysfunctional chewing pattern, they'll chew in that dysfunctional pattern. So yeah, my kids, when they wanted gum, I taught them, I said, you can have gum, but you have to split it in half. Yeah, chew it on both sides. Which is quite funny, because now if they see me mindlessly chewing gum and I've only got it on one side, they're, Mum, you've got to put it on both sides, so which is good. So this is where, so I work for Maya Munchie as well, one of their clinical advisors. I write a lot of their educational programs. Maya Munchie is a chewing appliance, so it is the gym for your jaw. It's designed as a neurosensory tool, helps to get your tongue, your jaw into the correct position, and it's just there to chew on, okay? It's really, really simple. It's a workout for your mouth. Gets that mouth closure, gets that nasal breathing. I don't have any association to Easy Tape. I just reused the slide from another presentation that I did for a company that did. So, but mouth taping is another way that we can start to retrain how to actually breathe through our nose at night. I don't recommend this for children under 4. And I recommend when parents are introducing mouth taping that you do it during the day first, and you actually have to train that musculature. You can't just tape a mouth and expect it to kind of recover, because you're not training those muscles to stay closed. I recommend that when they're watching TV, when they're gaming, something like that, put a little bit of tape, not taping the whole mouth, but just a little bit of tape. It's like a little proprioceptive reminder to the brain to keep the mouth closed. Do it during the day. You might do it during the day for like half a year, okay, before you introduce mouth taping at night. Mouth taping is very much an individual thing. There's the nasal strips that you can use as well. So what these are, you can use either magnets or the plastic strips. What they do is they actually pull out the nares and just open up the nares a little bit more. Yep, they have some influence for people that do have sort of more collapsing turbinates. It can help a little bit because you're starting to pull on that fascia. One of the adjustments that I learned that I do very rarely, but it is helpful, is we actually get a balloon up into the nasopharynx. Yeah, it's great though. Come on and I'll do it for you. It's so good, and that will help as well.
What about I've got a friend that's got sleep apnea.
Yes.
Told her to get a mouth gum. How does that work?
So that's just it. You know, when we looked at that picture where the tongue falls back, what it does is it just brings the tongue forward a little bit. Again, it's helping, but it's not retraining. Like it's.
I think she needed the proper setup, but
yeah.
It wasn't going to have that. So
and again, the sleep apnea machines, again, it's forced oxygen delivery, but they can actually make the problem worse because the masks actually push back even further, and they can drive that pattern even further. Yeah, it's not addressing the cause.
But some people, that's all they want.
Yeah.
They stay alive.
Oh, 100%. Yeah.
I'm wrapping it up because you guys have been really good for the whole session. Thank you so much for coming along.
Great.
And kind of, we got some time for Q&A if anyone's got some questions.
I'm here till we close up. Honestly, it's fine.
Yes, cool. Thank you. Any questions?
I do.
Yes.
You're saying about, so in utero you have your development starting, and if it is deficient, is there ways that you find with adjustments and stuff like that you can kind of reclaim that? Like if they're narrow and things like that, we can work dentally, but we see palate change and stuff. But like you were saying, up inside the maxilla, does it go further than just like the palate?
Oh, yeah, absolutely. So it's that whole cranial base. So it's not just the maxilla that we're seeing it in. We're going to see deficiencies all the way through. So we see sort of, So, but the thing is like we can have certain influencing factors positionally by getting like correct head placement, which is going to have that neuromuscular pull of all of those postural muscles. Huge, right? But one of the biggest driving inputs is the tongue positioning, right? So if that infant can't get that tongue elevation, they're going to, essentially, like if the tongue sits low, it pulls down on these pterygoid processes here, right? And then we're not getting, I didn't even talk about ear function in this, by the way. We're not getting this part of the sphenoid here needs to actually flare in cranial movement, okay? So when we've got the low tongue posture and it pulls down, it doesn't flare, so it locks up. And so this is where, as a chiropractor, we can get in there and we can do, like Loretta and I, we'll do sort of intraoral stuff and work through there. But if that child then goes out and sucks and swallows with a really low tongue posture, it's just going to drive that inferior vertical strain over and over and over again. Sorry? Yes, elongate, because you're pulling down on these structures here, which makes that everything through here kind of pull down inferiorly, which then it locks up that whole sphenobasilar junction, which then locks up our upper cervical spine, which then down-regulates our vagus function and so on and so on and so on. So there's a lot, yeah. And so that's where I love working with other professionals that are going to, because this is how I explain it to parents for tongue ties, for example. As I say, there's 3 components to a tongue tie. You've got physical restriction. It's a type 2 collagen fibre. It's not going to stretch, right? I can't diagnose that. I can't treat that, but I'm going to send you out to people who can. And that's where, your people that do the releases are going to address that. You've got the neuromuscular habit, right? That baby started swallowing in utero at around about 18 weeks. So they've created a pathway of moving their tongue in an abnormal way. Well, we're going to need to retrain that. That's where I work with, a doula or a lactation consultant or someone else that's going to help them retrain the latch by giving the right stimulus and positioning. And then we're going to have, there has been a significant amount of interference to that baby's ability to be able to wake up those primitive reflexes, and also structural interference, particularly if they've had any sort of birth trauma. And that's when, the chiro, the osteo, whoever's working with that system comes in. So you can't, I don't think anyway, you can't address it with just one thing. Yeah.
How do breech babies go?
Oh, terrible, I've got one at the moment. Yeah. So they just don't get... No, yeah. So they don't get the compressive forces because the cranial system's designed to over. I had a pediatric skull and my dog chewed it up, so I don't have the little baby one to show you. But I know, right? Yeah, no, it is. Literally, it did chew it up. So the cranial bones are designed to overlap and expand in like positioning in utero, but also particularly during the birth process. So when we have abnormal forces, whether it's from a breech positioning, whether it's from cesarean delivery, and we don't get that overlap and expansion, it starts to have massive flow-on effects, particularly with stimulating a lot of reflexive activity. Yeah, so I've got a little bub at the moment that was breech and born via cesarean section, and she's got massive issues at the moment. So
I think you'd be seeing more and more massive issues of babies, because a lot of them get them cut out and pulled out. more and more and more. And so,
Yeah.
you'll never be out of work, I just want to say.
Yeah, like I do. It's very rarely that I now see what I call the unicorn child. And also I've kind of niched myself into this. I see a lot of dysfunction, but I don't often see the kid that's actually,
Seeing that in the universe.
Agree.
yeah. Yeah.
And we need interesting.
Sorry, what was that?
It's exciting.
It's exciting.
When we
Yeah.
can see some of them.
Oh yeah, when we see normal, it's like, oh my goodness. Yeah. Yeah.
99% would be generous.
Yeah.
Yeah.
Yeah. There's a lot of dysfunction.
That's our niche. So many dysfunctional
Yeah.
people. So people ask me that, how many dysfunctional people? Well, that's what we do. So
It's kind of all of them. Yeah. Yeah.
You know when you're talking about sucking dummies?
Yeah.
So I had a dummy till I was 5 going to school. I was turning 6 in June, right? And as soon as Mum took the dummy off me, I remember back as a 5-year-old thinking, and I did it, you take that dummy off me, I'm going to suck my tongue. So to this day, I'm 63.
When you suck on your tongue.
I still suck my tongue. And I actually will get a selfie jet and do that. And I remember I used to be in class,
Yeah.
I'd zone out, just
Yep.
doing it, sucking my tongue
Yeah.
and doing that. And the
'Cause
teacher
you-
would be doing this because they thought there was something wrong, but it was me sucking my tongue.
Yeah, yeah. So your brain just didn't learn how to regulate your nervous system. Yeah, just so you. I mean, it's not.
Fancy giving me a dummy that long though. Afterwards,
Yeah.
ridiculous.
But again, she wouldn't have known any better.
No, that's right.
So you know,
100%,
yeah, you were happy. Yeah.
Oh, maybe that accounts for a bit.
I don't know. They also used to put brandy in the bottles. You know, like it's just they did what they had resources to do.
Yeah.
So yeah. Any other questions?
It was my mum. She's in it for during the day. Sleeping.
Yeah, you can sleep in them. So ideally, they're there to activate the system and train the system. So therefore, during the day, they're actually like, you're using them as an exercise. Yeah, I have got some people that utilise them at night time, but there's actually better devices you can use at night time. Yeah, better positional things. Yeah.
Great dummy replacement.
Yeah, really good dummy replacement. Yeah, which I talk about in the blog that I wrote recently. So, yes. All right. So I have my munchies available. You can get those at any stage from me as well. The other thing that I want to talk about is this is something that we're launching. It's called Handbook for the Human. It's coming out in a full book as well as other resources. And this is all about the first year of life and how to support the child's development in the first year of life. So it's about, yeah, I know, well, we're creating them to like have in office.
In the blue book.
Yeah.
Yeah,
I was thinking that this whole time.
Yeah. So this is just about like how does this child develop and how can we optimise that development. So this is a resource that we've put together and we're putting together in a lot more. We've got
People don't know the milestones that their
yeah,
child's meant to reach.
The milestone was giving birth.
yeah, yeah,
I did it.
yeah,
I did this.
yeah,
That's it.
yeah, yeah. So we just kind of get this little human that doesn't have an instruction manual. So we've just developed the instruction manual. That's pretty much it.
Coming out.
Well, we've got them now. So if you want to, just leave me your details and just say you're keen in having one of these because Mary ran out of the office today before I could grab a bunch of them. So I managed to grab the one off her desk, and then, but we've got these as a resource, particularly for practitioners, but we are putting together for parents as well. But how many times have you been in the office where people have wanted to know more? Well, how can I support this and what can I do?
And I don't deal with
Yeah.
and
Yeah.
we talk about
Yeah.
do you ever know about milestones with your child around the theme.
So these are done through the pillars of sleep, movement, nutrition, and then play, which is also part of connection. Yeah. So, and I've written a book, but it's not yet published. So, yeah, yes. Thank you all for coming along. I'll let you go home to your families. And of course, yeah, if you've got any other questions that come up, just fire them through to Healing Wave. Lovely. Thanks for coming in.
I was thinking, I'd like to catch up with you.
Oh, I know.
It's on my list, but when this
I-
was coming up, I was like,
Yeah.
I'm going to go.
I've been wanting to come in and just hang out for a day in your practice.
Yeah.
Yeah,
Vice
should be
versa.
awesome.
Like,
Yeah,
and-
I'm not super busy here yet, just because,
yeah.
building, having come from East Maitland, and then, yeah. Sorry, what was that?
Camera off.
Oh, yeah, I should do that. Thank you.
I know you can do it. Thank you.
All right.